Invasive fungal infections rank as the third leading cause of late-onset sepsis in neonatal intensive care units, creating a devastating burden of morbidity and mortality that extends far beyond the acute illness. The epidemiology reveals stark disparities based on birth weight that fundamentally change how we approach prevention and treatment strategies across different patient populations. The relationship between gestational age and infection risk follows a predictable but alarming pattern. Infants weighing less than 1,000 grams face infection rates between 5 and 20%, while those under 750 grams experience rates climbing as high as 20 to 30%. This inverse relationship between birth weight and fungal infection risk reflects the profound immunologic immaturity of extremely premature infants combined with their prolonged exposure to invasive interventions and broad-spectrum antibiotics. The mortality statistics underscore the serious nature of these infections. Overall mortality ranges from 20 to 40%, but central nervous system involvement pushes death rates above 50%. Even survivors face long-term consequences, with 57% developing significant neurodevelopmental impairment that affects cognitive, motor, and sensory development throughout childhood. The timing pattern provides important clinical insights. Most invasive fungal infections occur after 2 weeks of age, distinguishing them from early bacterial sepsis and reflecting the time required for colonization, antibiotic-induced flora disruption, and progressive immune system compromise that creates conditions favorable for fungal invasion. Understanding risk factors for neonatal candidiasis allows targeted prevention strategies and early recognition in high-risk populations. The multifactorial nature of fungal infection risk reflects the complex interplay between host vulnerability, medical interventions, and environmental exposures that characterize modern neonatal intensive care. Host factors center on extreme prematurity and its associated immunologic consequences. Very low birth weight infants under 1,500 grams and extremely low birth weight infants under 1,000 grams possess immature cellular and humoral immune systems that cannot mount effective antifungal responses. Gestational age under 28 weeks compounds this vulnerability through multiple mechanisms, including impaired neutrophil function, decreased complement activity, and compromised mucosal barrier integrity. Neutropenia and thrombocytopenia further compromise host defenses, whether occurring as complications of prematurity or as consequences of medical interventions. Medical interventions create the environmental conditions that promote fungal overgrowth and invasion. Broad-spectrum antibiotic therapy, lasting more than 5 days, disrupts normal bacterial flora that normally suppresses fungal proliferation through competitive inhibition and direct antifungal metabolite production. Third-generation cephalosporins demonstrate particular association with subsequent fungal infections because they eliminate gram-positive bacteria that provide natural antifungal protection. Central venous catheters provide direct pathways for bloodstream invasion while serving as surfaces for biofilm formation that protects fungi from both immune responses and antifungal medications. Parenteral nutrition containing lipid emulsions creates additional risk through mechanisms that include immune suppression and provision of nutrients that support fungal growth. Gastric acid suppression with H2 blockers or proton pump inhibitors eliminates an important natural barrier against fungal colonization of the gastrointestinal tract. The distribution of Candida species in neonatal infections carries important implications for treatment selection, prognosis prediction, and infection control measures. Each species demonstrates distinct epidemiologic patterns, antifungal susceptibility profiles, and clinical outcomes that influence management decisions. Candida albicans dominates neonatal fungal infections, comprising 50 to 70% of cases. This species generally maintains susceptibility to fluconazole, making it amenable to first-line antifungal therapy in most institutions. However, C. albicans produces robust biofilms that protect it from both antifungal agents and host immune responses, particularly when infections involve indwelling devices like central venous catheters. The biofilm production capability explains why device removal often becomes necessary for successful treatment of C. albicans infections. Candida parapsilosis accounts for 20 to 30% of neonatal fungal infections and demonstrates several distinctive characteristics. This species shows particular association with total parenteral nutrition and central venous catheter use, likely due to its ability to utilize lipids as nutritional sources and its propensity for biofilm formation on plastic surfaces. C. Parapsilosis spreads easily through horizontal transmission via healthcare worker hands, making it a common cause of nursery outbreaks. Despite these concerning epidemiologic features, C. parapsilosis infections generally carry better prognosis than other Candida species. Candida glabrata represents 5 to 10% of neonatal cases, but creates disproportionate clinical concern due to intrinsic fluconazole resistance. Infections with this species require alternative antifungal agents and carry higher mortality rates than fluconazole-susceptible species. Candida tropicalis, while less common, consistently demonstrates association with worse clinical outcomes and higher mortality rates compared to other species, making early identification and aggressive treatment particularly important. The pathophysiology of invasive candidiasis represents a complex progression from commensal organism to life-threatening pathogen, involving multiple steps that each present potential intervention points for prevention and treatment strategies. The process begins with colonization of skin and gastrointestinal tract surfaces. In healthy-term infants, normal bacterial flora maintains competitive inhibition that prevents fungal overgrowth. However, broad-spectrum antibiotic therapy disrupts this protective microbiome, creating ecological niches where Candida species can proliferate without bacterial competition. The initial colonization phase often remains asymptomatic, but establishes the reservoir from which subsequent invasive infection develops. Adherence to epithelial surfaces represents the crucial transition from superficial colonization to invasive potential. Candida organisms express surface adhesines that bind to epithelial cell receptors, allowing firm attachment that resists normal clearance mechanisms. This adherence phase becomes particularly important at sites of mucosal compromise, such as areas of necrotizing enterocolitis, or around indwelling medical devices. Penetration through epithelial barriers follows successful adherence and involves active invasion rather than passive translocation. Candida species secrete hydrolytic enzymes, including proteases and phospholipases, that degrade epithelial tight junctions and basement membrane components, creating pathways for deeper tissue invasion. This enzymatic destruction contributes to the tissue damage observed in invasive candidiasis. Bloodstream invasion marks the transition to systemic infection with potential for end organ seeding. Once in circulation, Candida can establish secondary infection sites in virtually any organ system, with particular predilection for the central nervous system, kidneys, liver, and eyes. Biofilm formation on indwelling devices creates protected communities that resist both antifungal therapy and immune clearance, explaining why device removal often becomes necessary for cure. Oral thrush represents the most recognizable superficial candidal infection, presenting with characteristic white plaques that coat the tongue and buccal mucosa in a distinctive cottage cheese pattern. When you attempt to scrape these plaques with a tongue depressor, they resist removal and bleed when forcibly removed. This bleeding response immediately distinguishes true thrush from simple milk residue that wipes away easily without trauma. The clinical significance extends beyond appearance because thrush interferes with effective feeding. These oral lesions cause genuine discomfort during sucking and swallowing, leading to feeding difficulties, poor weight gain, and potential dehydration. Treatment involves nystatin at 100,000 units applied 4 times daily, with emphasis on painting all oral surfaces thoroughly, not just visible plaques. Environmental decontamination of pacifiers and feeding equipment prevents reinfection, while extensive thrush in high-risk infants may require systemic antifungal therapy. Congenital cutaneous candidiasis tells a unique story through its timing and distribution patterns. When widespread skin lesions appear within 24 hours of birth, you're observing the aftermath of intrauterine infection that began during fetal development. This early presentation immediately distinguishes congenital infection from postnatally acquired disease. The skin manifestations present as generalized erythematous papules, pustules, and vesicles distributed across the entire body surface, followed by characteristic desquamation as inflammation resolves. The pathogenesis involves ascending infection from maternal vaginal candidiasis through compromised fetal membranes, explaining the frequent association with chorioamnionitis. Diagnosis combines clinical recognition with KOH preparation and fungal culture confirmation. Treatment decisions depend on extent and patient factors. Limited disease in term infants may respond to topical therapy, while widespread involvement or prematurity requires systemic antifungal treatment due to progression risk. Candidal diaper dermatitis creates one of dermatology's most diagnostic presentations through its distinctive beefy red appearance with sharp, well-demarcated borders. The pathognomonic finding involves satellite pustules, small pustular lesions scattered beyond the main inflammatory area that virtually confirm Candida involvement when present. Risk factors include prolonged moisture exposure, recent antibiotic use that eliminates protective bacterial flora, and frequent stooling that creates pH changes favoring fungal growth. Treatment requires both targeted antifungal therapy with topical nystatin or azoles applied 3 times daily and environmental modification through barrier creams and maintaining dry conditions whenever possible. Invasive candidiasis presents with frustratingly nonspecific signs that mimic bacterial sepsis, making early recognition challenging yet critically important given the associated high mortality. Temperature instability, feeding intolerance, apnea, bradycardia, and respiratory deterioration all occur commonly but lack diagnostic specificity. Laboratory findings provide more valuable diagnostic clues than physical examination. Thrombocytopenia below 100,000 emerges as the single most important laboratory marker, resulting from bone marrow suppression and peripheral platelet consumption. Blood glucose abnormalities and metabolic acidosis reflect systemic inflammatory response and potential progression to septic shock. Most concerning, clinical deterioration despite appropriate antibacterial therapy should immediately raise suspicion for fungal infection, as this pattern suggests a pathogen not covered by standard bacterial antibiotics. Recognition of these subtle patterns becomes crucial because delayed diagnosis allows progression to multiple organ involvement with dramatically worsened prognosis. Diagnosing invasive candidiasis presents significant challenges because blood culture sensitivity reaches only 50%, meaning negative cultures cannot exclude disease in high-risk patients. This limitation necessitates strategic approaches, including multiple blood cultures and paired central versus peripheral specimens to maximize detection probability. Urine culture requires suprapubic aspiration or catheterization for reliable results, with 10,000 colony-forming units per milliliter considered significant. Bag specimens remain unreliable for definitive diagnosis. Lumbar puncture becomes essential when candidemia is documented because central nervous system involvement occurs frequently and worsens prognosis dramatically. However, cerebrospinal fluid analysis can appear deceptively normal in early fungal meningitis, with normal cell counts and glucose levels despite active infection. This emphasizes the critical importance of fungal culture rather than relying on routine cerebrospinal fluid parameters. Beta-D-glucan testing shows promise as a non-culture method but lacks adequate pediatric validation data, limiting current clinical utility until age-specific interpretation criteria become established. When invasive candidiasis escapes initial containment, it seeds distant organs through hematogenous spread, creating secondary infection sites that dramatically worsen prognosis and complicate treatment. Understanding these dissemination patterns helps guide both diagnostic evaluation and monitoring strategies once invasive infection is confirmed. Central nervous system involvement occurs in approximately 50% of invasive candidiasis cases, making it the most common site of end organ seeding. The spectrum ranges from meningoencephalitis with diffuse brain inflammation to focal complications including brain abscesses and ventriculitis. The blood-brain barrier provides limited protection against fungal invasion, particularly in premature infants whose barrier function remains immature. CNS involvement carries the worst prognosis among all dissemination sites, with mortality exceeding 50% and survivors facing high rates of severe neurodevelopmental impairment. Renal dissemination affects 5 to 30% of patients, creating unique complications that can persist long after systemic infection resolves. Fungal balls form when Candida organisms aggregate within the renal collecting system, creating obstructive masses that block urine flow. These collections can cause hydronephrosis, urinary retention, and progressive renal failure. Unlike bacterial infections that typically respond to antimicrobial therapy alone, fungal balls often require urological intervention for mechanical removal combined with antifungal treatment. Cardiac involvement occurs in 5 to 10% of cases, manifesting as endocarditis or intracardiac fungal masses. The immature immune response in neonates provides inadequate defense against fungal adherence to valve surfaces, while indwelling catheters create additional sites for biofilm formation that can embolize to cardiac structures. Beyond the major organ systems, invasive candidiasis can seed virtually any anatomic site, creating diverse clinical manifestations that require systematic evaluation once systemic infection is diagnosed. These additional sites of involvement often determine long-term outcomes even when systemic infection responds to antifungal therapy. Ophthalmologic involvement deserves special attention because it occurs in up to 50% of invasive candidiasis cases, yet frequently remains asymptomatic until advanced disease develops. Chorioretinitis represents the most common manifestation, appearing as white, fluffy retinal lesions that can progress to endophthalmitis with intraocular inflammation and potential vision loss. The absence of obvious symptoms makes routine ophthalmologic examination mandatory for all patients with documented invasive candidiasis, as early detection allows targeted treatment before irreversible damage occurs. Hepatosplenic candidiasis creates a particularly challenging clinical scenario, characterized by persistent fever and ongoing positive cultures despite apparently adequate antifungal therapy. Multiple microabscesses throughout liver and spleen tissue create protected environments where fungi resist both antifungal penetration and immune clearance. This pattern often requires prolonged treatment courses and may necessitate combination antifungal therapy to achieve resolution. Bone and joint involvement remains rare in neonates, but carries significant implications for long-term growth and development when it occurs. Candidal osteomyelitis and septic arthritis require extended treatment courses similar to bacterial bone infections, often lasting months rather than weeks. The growing skeleton proves particularly vulnerable to fungal invasion, with potential for growth plate damage and subsequent limb deformities if treatment proves inadequate or delayed. Amphotericin B remains the cornerstone of therapy for invasive candidiasis in neonates, despite its reputation for causing significant toxicity. This polyene antifungal works by binding to ergosterol in fungal cell membranes, creating pores that lead to cell death. Its broad spectrum covers virtually all Candida species, making it the first-line choice when species identification remains pending or when resistant organisms are suspected. Conventional amphotericin B deoxycholate is dosed at 1 mg per kilogram daily, given intravenously. The drug demonstrates excellent penetration into the central nervous system, reaching therapeutic concentrations in cerebrospinal fluid that make it particularly valuable for treating sinus involvement. This penetration capability becomes crucial because many other antifungal agents achieve poor brain tissue levels. However, the benefits come with substantial toxicity concerns that require careful monitoring throughout treatment. Nephrotoxicity emerges as the most significant adverse effect, necessitating daily monitoring of serum creatinine, potassium, and magnesium levels. The drug causes direct tubular damage that can lead to acute kidney injury, electrolyte wasting, and long-term renal impairment if not recognized early. Hematologic toxicity manifests as anemia and thrombocytopenia through bone marrow suppression mechanisms. Infusion reactions, including fever, chills, and hypotension, occur commonly and may require premedication with acetaminophen and diphenhydramine. Liposomal formulations reduce toxicity by encapsulating the drug in lipid vesicles that preferentially target infected tissues while sparing normal organs. However, these preparations remain reserved for situations where conventional amphotericin B causes unacceptable toxicity due to their significantly higher cost. Treatment duration typically extends 14 to 21 days beyond documented clearance of fungemia and resolution of clinical signs. Fluconazole fills multiple important roles in neonatal antifungal therapy through its excellent safety profile, predictable pharmacokinetics, and broad clinical utility. This triazole antifungal inhibits ergosterol synthesis by blocking the enzyme linosterol demethylase, disrupting fungal cell membrane integrity without the toxicity associated with amphotericin B. The clinical indications for fluconazole span both prophylactic and therapeutic applications. Prophylaxis in extremely low birth weight infants reduces invasive candidiasis rates significantly, though the optimal patient selection criteria continue to evolve. For therapeutic use, fluconazole provides excellent activity against Candida albicans and Candida parapsilosis, the two most common species in neonatal infections. Its role as step-down therapy allows transition from amphotericin B once clinical improvement occurs, and species identification confirms susceptibility. Dosing requires an initial loading dose of 12 milligrams per kilogram to rapidly achieve therapeutic levels, followed by maintenance dosing at 6 milligrams per kilogram daily. The drug's excellent oral bioavailability, approaching 100%, allows seamless transition between intravenous and oral administration based on clinical status and feeding tolerance. Central nervous system penetration rivals that of amphotericin B, making fluconazole valuable for CNS candidiasis when susceptible species are involved. Critical limitations include intrinsic resistance patterns that must guide species-specific therapy decisions. Candida glabrata demonstrates intrinsic resistance to fluconazole, while Candida krusei shows complete resistance. These resistance patterns make species identification essential for appropriate antifungal selection, as fluconazole therapy will fail against these organisms regardless of dosing or duration. Beyond amphotericin B and fluconazole, several additional antifungal agents provide options for specific clinical scenarios, though their use in neonates remains limited by safety concerns, pharmacokinetic uncertainties, or inadequate efficacy data in this population. Echinocandins, exemplified by micafungin, represent a newer class of antifungals that inhibit beta-glucan synthesis in fungal cell walls. These agents demonstrate excellent activity against most Candida species, including fluconazole-resistant strains, making them valuable for salvage therapy when first-line agents fail. However, poor central nervous system penetration limits their utility for CNS candidiasis, and safety data in neonates remains limited compared to older antifungal agents. Flucytosine serves as adjunctive therapy for central nervous system disease due to excellent cerebrospinal fluid penetration and synergistic activity with amphotericin B. The combination theoretically allows lower amphotericin B doses while maintaining efficacy, potentially reducing nephrotoxicity. However, flucytosine carries significant toxicity concerns, including bone marrow suppression and hepatotoxicity, requiring careful monitoring of drug levels and hematologic parameters. Voriconazole remains relegated to very limited use in neonates due to complex pharmacokinetics, significant drug interactions, and concerning adverse effects including photosensitivity reactions. The unpredictable metabolism in neonates makes dosing difficult, while the potential for serious skin reactions with light exposure creates practical management challenges in the hospital environment. These alternative agents generally serve as rescue therapy when conventional options fail or prove intolerable, requiring careful consideration of risks versus benefits in each clinical situation. Successful management of invasive candidiasis requires a systematic approach that addresses both the infection itself and the underlying factors that allowed it to develop. The cornerstone principle involves removing foreign bodies whenever medically feasible, because biofilm formation on indwelling devices creates protected environments where fungi resist both antifungal therapy and immune clearance. Central line removal emerges as the most critical intervention in catheter-related candidemia. Biofilms form rapidly on catheter surfaces, creating complex three-dimensional structures that protect organisms from antifungal concentrations that would easily kill planktonic fungi. When hemodynamic instability or lack of alternative access makes immediate removal impossible, temporary retention may be necessary while stabilizing the patient and securing alternative vascular access. Once systemic antifungal therapy begins, comprehensive evaluation for end organ involvement guides both immediate management and long-term monitoring strategies. dilated ophthalmologic examination becomes mandatory because chorioretinitis occurs in up to 50% of cases, yet remains asymptomatic until advanced disease develops. Renal ultrasound identifies fungal balls or hydronephrosis that may require urological intervention beyond antifungal therapy. Echocardiography evaluates for endocarditis when candidemia persists despite appropriate therapy, while head ultrasound or MRI detects central nervous system involvement that dramatically alters treatment duration and prognosis. Microbiologic monitoring through repeat blood cultures every 48 hours documents clearance of fungemia and guides treatment duration decisions. Persistent positive cultures suggest inadequate therapy, undrained infection sources, or resistant organisms requiring treatment modification. Treatment duration for invasive candidiasis varies dramatically based on the extent of disease involvement and response to therapy. Understanding these duration principles prevents both inadequate treatment that leads to relapse and unnecessarily prolonged therapy that increases toxicity risk. Uncomplicated candidemia requires 14 days of antifungal therapy after the last positive blood culture combined with resolution of clinical signs attributable to the infection. This duration ensures adequate clearance while minimizing exposure to potentially toxic antifungal agents. The requirement for both microbiologic clearance and clinical improvement prevents premature discontinuation in patients who clear fungemia but continue showing signs of ongoing infection. Central nervous system candidiasis demands much more aggressive treatment due to poor antifungal penetration into brain tissue and the devastating consequences of inadequate therapy. Treatment continues for at least 21 days after cerebrospinal fluid sterilization, with total treatment courses often extending 4 to 6 weeks. The prolonged duration reflects the challenge of achieving therapeutic antifungal concentrations in brain tissue and the high relapse rates observed with shorter treatment courses. Endocarditis requires 6 weeks of systemic antifungal therapy combined with surgical intervention when feasible. The extensive treatment duration addresses the poor vascular supply of infected valve tissue and the protective environment created by fungal vegetations that resist both antifungal penetration and immune clearance. Disseminated disease involving multiple organ systems requires individualized treatment approaches based on the specific sites involved and response to therapy. Long-term monitoring for relapse becomes essential because inadequately treated invasive candidiasis can recrudesce months after apparent cure. Fluconazole prophylaxis represents one of the most successful targeted prevention strategies in neonatal medicine, dramatically reducing invasive candidiasis rates in the highest risk population through carefully selected patient criteria and evidence-based dosing regimens. The indications focus on infants at greatest risk for invasive candidiasis, those with birth weights under 1,000 grams or gestational ages under 27 weeks. These criteria identify extremely low birth weight infants whose immature immune systems, prolonged hospitalization, and extensive invasive interventions create perfect conditions for fungal infection development. The specificity of these criteria prevents unnecessary antifungal exposure in lower-risk populations, while concentrating prevention efforts where they provide maximum benefit. To establish dosing regimens provide flexibility based on institutional preferences and patient factors. The lower dose regimen uses 3 mg per kilogram twice weekly, while the higher dose approach employs 6 mg per kilogram twice weekly. Both regimens demonstrate significant efficacy in reducing invasive candidiasis, though some evidence suggests superior protection with higher dosing in the most premature infants. Timing and duration guidelines optimize prevention while minimizing resistance development. Prophylaxis typically begins between days 3 and 7 of life, after initial stabilization but before peak risk periods for invasive candidiasis. Treatment continues until multiple risk factors resolve, discontinuation of broad-spectrum antibiotics, and total parenteral nutrition combined with central venous catheter removal. This approach targets the highest risk period while preventing unnecessarily prolonged antifungal exposure. Clinical trials demonstrate 80 to 90% reductions in invasive candidiasis rates, translating to substantial decreases in mortality and long-term neurodevelopmental impairment in this vulnerable population. Fluconazole prophylaxis decisions require careful weighing of substantial benefits against potential risks and unintended consequences. Understanding both sides of this equation helps guide evidence-based implementation strategies that maximize benefits while minimizing adverse outcomes. The benefits extend beyond simple infection prevention to encompass broader improvements in patient outcomes. Decreased invasive candidiasis rates translate directly to reduced mortality in extremely low birth weight infants, as invasive fungal infections carry 20 to 40% mortality rates even with optimal treatment. The prevention of invasive candidiasis also reduces long-term neurodevelopmental impairment, as 57% of survivors develop significant cognitive, motor, or sensory deficits. Economic analyses demonstrate cost-effectiveness through reduced length of stay, decreased antifungal treatment costs, and prevention of expensive long-term complications. However, legitimate concerns about resistance development and ecological effects require ongoing surveillance and careful monitoring. Prolonged fluconazole exposure theoretically selects for resistant organisms, particularly Candida glabrata and Candida krusei, strains with intrinsic or acquired resistance. Some institutions report increases in fluconazole-resistant species during prophylaxis programs, though the clinical significance remains unclear. Drug interactions with commonly used neonatal medications, particularly those metabolized through cytochrome P450 pathways, create additional monitoring requirements. Surveillance culture programs become essential components of successful prophylaxis initiatives. Regular monitoring of Candida species distribution and antifungal susceptibility patterns allows early detection of resistance trends that might warrant program modification. Unit-based protocols ensure consistent implementation while providing flexibility to address institution-specific epidemiologic patterns and resistance concerns. Preventing neonatal candidiasis requires attacking multiple risk factors simultaneously because no single intervention adequately addresses the complex web of factors that lead to invasive fungal infection. The most successful programs combine evidence-based strategies into comprehensive bundles rather than relying on individual approaches. Antibiotic stewardship provides the foundation of prevention because broad-spectrum antibiotics represent the primary driver of candidal overgrowth. Every additional day of third-generation cephalosporin therapy increases fungal infection risk by eliminating protective bacteria that normally suppress Candida proliferation. Prompt de-escalation to narrow-spectrum agents once cultures return preserves remaining protective flora. Avoiding gastric acid suppression with H2 blockers or proton pump inhibitors, unless clearly indicated, eliminates another pathway for fungal colonization. Early enteral feeding initiatives promote normal gut flora development, while judicious limitation of total parenteral nutrition reduces both central line dependence and the glucose-rich environment that supports fungal growth. Meticulous central venous catheter care through evidence-based insertion and maintenance protocols prevents catheter-related infections while extending device lifespan. Hand hygiene remains the fundamental intervention that impacts every patient interaction, as healthcare workers' hands frequently transmit Candida organisms between patients. Lactoferrin supplementation shows promise through its natural antifungal properties and immune system modulation effects, though implementation varies between institutions. The bundle approach proves most effective because it combines multiple evidence-based interventions into standardized protocols that address the multifactorial nature of fungal infection risk more comprehensively than any single strategy could achieve alone. Aspergillus infections represent the nightmare scenario in neonatal infectious diseases. Mercifully rare, but absolutely devastating when they occur in the most vulnerable patients. These mold infections create challenges that differ fundamentally from the yeast infections we typically encounter, requiring heightened awareness of specific risk patterns and environmental exposures. Extreme prematurity creates the primary vulnerability through profoundly immature immune systems that cannot mount effective responses against mold organisms. The neutrophil dysfunction common in extremely premature infants proves particularly problematic because these cells provide the primary defense against Aspergillus invasion. Prolonged corticosteroid therapy compounds this vulnerability by further suppressing both cellular immunity and inflammatory responses needed for fungal clearance. Environmental exposure during hospital construction or renovation introduces the airborne spores that establish infection. Unlike Candida organisms that arise from normal flora, Aspergillus spores must be inhaled or directly inoculated from the environment, making construction activity a major risk factor that requires enhanced infection control measures. Pulmonary involvement dominates the clinical picture because airborne acquisition leads to initial respiratory tract infection. Early signs mimic bacterial pneumonia with respiratory distress and chest infiltrates. But the rapid progression and poor response to antibacterial therapy should alert clinicians to consider fungal causes. Cutaneous aspergillosis appears as primary infection at sites of skin breakdown or invasive procedures, creating characteristic ulcerative lesions with black eschar formation that can serve as portals for systemic dissemination. Central nervous system involvement carries the worst prognosis because Aspergillus demonstrates unique angioinvasive properties, invading blood vessel walls and causing thrombosis with hemorrhagic infarction. Even successful antifungal treatment cannot reverse the vascular damage, making prevention through environmental control and early recognition absolutely critical. Treatment requires aggressive antifungal therapy with either voriconazole or amphotericin B, though outcomes remain poor even with optimal management. Beyond the well-recognized threats of Candida and Aspergillus, several other fungal organisms occasionally cause neonatal infections, each presenting unique epidemiologic patterns and clinical challenges that require specific recognition strategies. Cryptococcal infections occur so rarely in neonates that many practitioners never encounter cases during their careers. When infection does develop, it typically affects severely immunocompromised patients with underlying cellular immune defects or acquired immune suppression. Central nervous system involvement predominates, creating chronic meningoencephalitis with insidious onset that can be easily missed because early symptoms remain subtle and nonspecific in neonates. Pneumocystis infections target immunocompromised infants, particularly those with congenital immunodeficiency syndromes or prolonged corticosteroid exposure that suppresses cellular immunity. The classic presentation involves progressive pneumonia with bilateral interstitial infiltrates and severe hypoxemia that responds poorly to conventional respiratory support measures, requiring high index of suspicion for diagnosis. Malassezia deserves special attention because it demonstrates unique lipid dependence that creates distinctive epidemiologic associations. This organism requires lipid-containing media for growth, explaining its particular association with total parenteral nutrition use and central venous catheter infections. The lipid requirement means Malassezia thrives in the lipid-rich environment created by TPN solutions while remaining relatively uncommon in patients not receiving parenteral nutrition. Trichosporon emerges as an increasingly recognized pathogen in neonatal intensive care units, particularly those with extensive antifungal prophylaxis programs that may create selective pressure favoring unusual organisms. This yeast presents treatment challenges through intrinsic resistance to echinocandin antifungals and variable susceptibility patterns to other available agents, making species identification and susceptibility testing crucial for appropriate therapy selection. Antifungal resistance represents one of the most critical challenges facing modern neonatal fungal infection management, fundamentally altering treatment decisions through both predictable intrinsic patterns and concerning trends in acquired resistance development. The intrinsic resistance patterns provide the most reliable guidance for treatment selection because they remain constant and predictable across isolates. Candida glabrata demonstrates inherent reduced susceptibility to fluconazole through altered target enzyme expression, making fluconazole therapy ineffective regardless of dosing strategies or treatment duration. Candida cruzae shows even more complete intrinsic resistance to fluconazole with minimal inhibitory concentrations that far exceed achievable serum levels, even with maximum dosing. These intrinsic resistance patterns make species identification absolutely essential before initiating fluconazole therapy, particularly in critically ill neonates where treatment delays can prove fatal. The clinical implication is straightforward. If blood cultures grow either C. glabrata or C. cruzae, fluconazole will fail, and alternative antifungal agents must be selected immediately, More concerning for the future, acquired resistance development now affects previously reliable fluconazole-susceptible species, including Candida albicans and Candida parapsilosis. These resistance mechanisms typically involve upregulation of efflux pumps that actively remove antifungal drugs from fungal cells or mutations in target enzymes that reduce drug-binding affinity. While resistance rates remain relatively low in most centers, isolated outbreaks of resistant strains create significant management challenges. Regular monitoring of local susceptibility patterns becomes crucial for detecting emerging resistance trends before they compromise patient care. The relationship between prophylaxis programs and resistance development remains complex. While prophylaxis dramatically reduces invasive disease rates, it theoretically creates selective pressure favoring resistant organisms that requires ongoing surveillance to detect early warning signs. When addressing fungal infections in our most vulnerable patients, it's essential to understand that our approach differs significantly from bacterial or viral pathogens. Standard precautions are sufficient for managing fungal infections in neonates. Unlike certain resistant bacterial infections, fungi typically do not require enhanced contact precautions or specialized PPE beyond what we routinely employ. Hand hygiene remains absolutely critical and serves as our primary defense mechanism. Candida species and other fungi can persist on healthcare workers' hands and contaminated surfaces. Alcohol-based hand sanitizers are effective against most fungal pathogens, but thorough hand washing with soap and water remains the gold standard, particularly when hands are visibly soiled. Environmental cleaning takes on heightened importance in the NICU setting. Fungi can survive on surfaces for extended periods, and our immunocompromised neonates are particularly susceptible to environmental acquisition. Regular disinfection with appropriate antifungal agents is paramount. No special isolation is required for most fungal infections. Unlike airborne pathogens, fungi in the NICU setting typically spread through direct contact or environmental contamination rather than respiratory droplets. We must monitor vigilantly for horizontal transmission, particularly with Candida auris and other emerging resistant fungi. Surveillance cultures and molecular typing can help identify potential outbreaks early. Finally, construction infection control cannot be overlooked. Environmental fungi, particularly Aspergillus species, can become aerosolized during construction activities, posing significant risks to our immunocompromised neonatal population. Proper containment and air filtration systems are essential during any construction or renovation activities near the NICU. Quality improvement initiatives for neonatal fungal infections require comprehensive measurement strategies that capture both process indicators and patient outcomes to drive meaningful improvements in care quality and safety. Invasive candidiasis rates provide the fundamental outcome measure, typically expressed as infections per 1,000 patient days, or stratified by birth weight categories to enable meaningful comparisons between units and tracking of trends over time. These rates must account for case mix differences because infection risk varies dramatically between term and extremely premature populations. Prophylaxis compliance monitoring ensures that prevention strategies reach intended patients consistently and appropriately. This includes tracking both initiation rates in eligible patients and adherence to recommended dosing and duration protocols, as incomplete prophylaxis may provide inadequate protection while contributing to resistance development. Antifungal utilization analysis examines both prophylactic and therapeutic use patterns to identify opportunities for optimization. This includes monitoring appropriate species, directed therapy, treatment duration compliance, and unnecessary antifungal exposure that increases resistance risk without clinical benefit. Resistance pattern surveillance tracks local epidemiology changes that may require protocol modifications or empiric therapy adjustments. Regular susceptibility testing and species distribution monitoring help detect emerging resistance before it compromises patient outcomes. Mortality outcomes and neurodevelopmental follow-up provide the ultimate measures of program effectiveness, as preventing invasive candidiasis should translate to improved survival and long-term developmental outcomes in high-risk infants. Cost-effectiveness analysis demonstrates the economic value of prevention programs by quantifying savings from reduced infection rates, shorter hospital stays, and decreased long-term care needs. These comprehensive metrics create accountability for infection prevention efforts while identifying areas requiring focused improvement interventions. The landscape of neonatal fungal infections continues evolving rapidly, driven by new pathogen emergence, changing resistance patterns, and innovative therapeutic approaches that promise to transform how we prevent and treat these devastating infections in the coming years. Multi-drug-resistant Candida auris represents perhaps the most concerning development in medical mycology, creating a global health threat that has begun appearing in some neonatal units. This organism demonstrates intrinsic resistance to multiple antifungal classes simultaneously, often leaving only a single effective agent for treatment. Unlike other Candida species, C. auris spreads easily between patients through environmental contamination and healthcare worker transmission, requiring enhanced infection control measures, including contact isolation and specialized environmental cleaning protocols. Azole resistance patterns continue expanding beyond the predictable intrinsic resistance of C. glabrata and C. cruce to affect previously susceptible species through acquired mechanisms. These emerging resistance patterns threaten fluconazole's role as first-line therapy and prophylaxis, potentially requiring fundamental changes to current treatment algorithms if resistance rates continue climbing. New antifungal agents under development offer hope for overcoming current resistance challenges, including novel classes with unique mechanisms of action that may prove effective against multi-drug-resistant organisms. Biofilm disruption strategies represent particularly promising approaches because biofilm formation protects fungi from both antifungal therapy and immune responses, making these protective structures attractive therapeutic targets. Combination therapy research explores synergistic interactions between existing antifungals that may enhance efficacy while potentially reducing individual drug toxicity through lower dosing requirements. Precision medicine approaches seek to tailor antifungal selection and dosing based on individual patient factors, including genetic polymorphisms affecting drug metabolism, specific organism characteristics, and host immune status. Certain neonatal populations face dramatically elevated risks for fungal infections due to their underlying conditions, required interventions, or anatomical vulnerabilities that demand modified surveillance strategies and more aggressive management approaches. ECMO patients represent the highest risk population for invasive candidiasis because extracorporeal circulation creates massive foreign body surface area for biofilm formation, while the complex circuitry makes device removal impossible during critical support periods. The combination of prolonged vascular access, systemic anticoagulation, and frequent blood sampling creates perfect conditions for fungal seeding and proliferation. Post-surgical patients require intensified surveillance because surgical stress compromises immune function, while invasive procedures create new portals for infection. Abdominal surgery carries particular risk due to potential bowel flora translocation, while cardiac surgery patients face both immune suppression from cardiopulmonary bypass and increased endocarditis risk from intracardiac hardware. Congenital heart disease patients demonstrate elevated endocarditis risk because abnormal blood flow patterns and structural defects create turbulence that promotes fungal adherence to valve surfaces. The presence of prosthetic materials further increases risk, while making treatment more challenging, because biofilm formation on synthetic surfaces resists antifungal therapy. Necrotizing enterocolitis patients face unique risks when bowel perforation allows direct peritoneal seeding with enteric flora, including Candida organisms. The inflammatory environment and impaired gut barrier function create conditions favoring fungal translocation and systemic dissemination. Immunodeficiency patients, whether congenital or acquired, require the most aggressive management approaches because their compromised immune systems cannot provide adequate defense against fungal invasion once it begins. Early empiric therapy and prolonged treatment courses become necessary to compensate for inadequate host responses. The long-term consequences of invasive candidiasis extend far beyond the acute illness, creating lifelong disabilities that profoundly impact affected children and their families while generating substantial societal costs through ongoing medical care and support service needs. Neurodevelopmental delays affect 57% of survivors, reflecting both direct central nervous system damage from fungal invasion and secondary injury from systemic inflammation and prolonged critical illness. These delays encompass multiple domains, including cognitive function, language development, and adaptive skills that become apparent as children reach developmental milestones and enter school systems requiring specialized educational support. Cerebral palsy develops in 25% of survivors, representing permanent motor dysfunction that ranges from mild coordination difficulties to severe spasticity requiring lifelong assistive devices and intensive physical therapy. The motor impairments often result from periventricular white matter injury caused by fungal invasion or inflammatory damage during the acute infection period. Sensory impairments create additional challenges, with hearing loss affecting 10% of survivors and vision impairment occurring in 15%. These sensory deficits often result from direct organ involvement during disseminated infection or from ototoxic effects of prolonged antifungal therapy, particularly amphotericin B treatment courses. Chronic lung disease develops through multiple mechanisms, including direct pulmonary invasion, prolonged mechanical ventilation requirements during acute illness, and systemic inflammatory responses that damage developing lung tissue. Growth impairment reflects both the metabolic demands of chronic infection and ongoing medical complications that interfere with normal nutrition and development. The comprehensive nature of these long-term consequences makes early intervention services essential for optimizing developmental outcomes in survivors, requiring coordinated multidisciplinary care that addresses medical, educational, and developmental needs throughout childhood and into adulthood. The comprehensive nature of invasive candidiasis complications demands systematic long-term monitoring that extends well beyond hospital discharge, creating a roadmap for detecting and addressing sequelae before they become irreversible or severely impact quality of life. Neurodevelopmental assessment forms the cornerstone of follow-up because the 57% rate of developmental delays requires early detection to optimize intervention timing. These evaluations should begin by 6 months corrected age and continue at regular intervals throughout early childhood, using standardized tools that can detect subtle deficits in cognitive, motor, and language development before they significantly impact functional outcomes. Hearing evaluation becomes particularly crucial given the dual risks from direct fungal involvement and ototoxic antifungal therapy, especially prolonged amphotericin B courses. Auditory brainstem response testing should occur before hospital discharge, with follow-up audiometry at regular intervals, because hearing loss can be progressive and may not manifest immediately after treatment completion. Vision screening addresses the risk of chorioretinitis and endophthalmitis that can cause permanent visual impairment if undetected. Ophthalmologic examination should include dilated fundoscopy to detect retinal scarring or ongoing inflammation that might require additional treatment or visual rehabilitation services. Growth monitoring tracks both physical development and nutritional status, as invasive candidiasis can create long-term growth impairment through multiple mechanisms including chronic inflammation, prolonged critical illness, and ongoing medical complications that interfere with normal caloric intake and utilization. Pulmonary and renal function assessment addresses organ-specific complications that may not become apparent until months after acute infection resolves. Early intervention referral becomes essential when any deficits are detected, as timely therapeutic services can significantly improve developmental trajectories and functional outcomes. The future of neonatal fungal infection management stands at the threshold of revolutionary advances that promise to transform both prevention strategies and treatment outcomes through innovative approaches targeting every aspect of the host-pathogen interaction. Novel antifungal agents under development offer hope for overcoming current resistance challenges through entirely new mechanisms of action that bypass existing resistance pathways. These include compounds targeting fungal cell wall synthesis through novel enzyme inhibition, drugs that disrupt essential metabolic pathways unique to fungi, and agents that exploit fungal-specific cellular structures not found in human cells. Biofilm prevention represents a paradigm shift from treating established infections to preventing the protective structures that make fungi so difficult to eradicate once they establish device-related infections. Strategies include surface modifications that prevent initial fungal adherence, antimicrobial coatings that release antifungal agents locally, and combination approaches that both prevent biofilm formation and disrupt existing biofilms. Immunomodulation therapy recognizes that the immature neonatal immune system contributes significantly to infection susceptibility and poor outcomes. Future approaches may include targeted immune enhancement to improve antifungal defenses while avoiding excessive inflammation that damages developing organs. Rapid diagnostic techniques promise to revolutionize clinical decision-making by providing species identification and susceptibility results within hours rather than days. These advances include molecular methods for direct detection from clinical specimens and automated systems that can provide real-time monitoring of treatment response. Personalized prophylaxis strategies seek to identify the highest-risk patients while avoiding unnecessary antifungal exposure in those unlikely to benefit. This precision approach combines clinical risk factors with biomarkers and genetic factors to tailor prevention strategies to individual patient risk profiles.